Right. I'd like to introduce to you our next presenter, Dr. Suchak. Dr. Suchak is a clinician educator and an associate professor in the Department of Geriatrics at the Florida State University College of Medicine here in beautiful Tallahassee, Florida. She is the medical director of Big Bend Hospice, which provides a full range of programs and services to patients with advanced illness and their families in the Big Bend area. She is a board certified through the American Board of Internal Medicine in the internal medicine, geriatric medicine, and hospice and palliative medicine. She has presented regionally, nationally, and internationally on geriatric medicine, hospice, and palliative care topics. Dr. Suchak is also a past president of the Florida Geriatric Society. She's a member of the American Board of Internal Medicine, Geriatric Medicine Board, Exam Committee, and serves on the Florida Department of Health Alzheimer's Disease Research Grant Advisory Board by the American Geriatric Society. And in 2016, Dr. Suchak received the Outstanding Senior Faculty Educator of the Year Award by the FSU Com Faculty Council. So congratulations on that award and welcome, Dr. Suchak.
Thank you so much, Miss Alexander. Appreciate the kind words. You've been very gracious. I'm also very appreciative that many people have joined in today to listen to us. It's our privilege and pleasure to actually present some information regarding dementia, regarding Alzheimer's disease, and to be able to answer some questions. I'm going to now just check to see if I can share my screen with everyone properly. And is that what everybody is seeing?
Yes, it's perfect. Awesome.
Okay. And I apologize, that's my phone telling me that I am late to my start of my speech. So here I am. Thank you once again for the kind introduction, Ms. Alexander. And typically, you know, when I have presentations, I talk about financial disclosure. So typically, as part of the FSU College of Medicine, I typically would not have any financial relationships to identify, but I do want to make a point about how, as a geriatrician, the typical salary of a geriatrician is not even on the radar when you look at some publications that talk about physician salaries. So you know for sure that when someone becomes a geriatrician, it's not for the money, because this is an example of a publication where geriatrics doesn't even exist on their table because the salary is not a factor at all. But there is a silver lining, because doctors who treat seniors are amongst the most satisfied professionals. And typically this is a little bit opposite of what medical students choose as a future career. We already mentioned that I'm part of the FSU College of Medicine. I want to emphasize that our mission is to educate our students to become clinicians who would serve underserved, minority, rural, and elderly populations, as well as develop compassionate clinicians who provide patient-centered care. I also have another hat as the Big Bend Hospice Medical Director with its head office in Tallahassee. It has existed for 35 years, and it has been impacting its 8-county service area in the Big Bend for that long. This is just a reminder of some of the things I'll be talking about, and I'll periodically bring that slide back up to remind myself and to remind us what I'll be talking about next. And just as a matter of introduction, I would like to talk a little bit about some of the terminology used when we talk about dementia and related cognitive disorders. And cognition is one of the higher functions of the brain that allows us to think and make decisions and then behave and act on those decisions. There are multiple cognitive domains, and in conditions with dementia, including Alzheimer's disease, one or more of these may be affected over time, and when the condition progresses, more of these cognitive domains will get affected. Attention would be the ability to stay focused, in the presence of distractions. Executive functioning is the ability to execute and plan a task, to plan and execute a task. And so if someone had been an excellent chef and had run restaurants or TV shows, is now unable to plan and execute a simple meal at home, could be a concern. And learning and memory, retaining new information, that is commonly seen publicly as one of the common signs of a cognitive disorder. Language, the ability to not just speak, but also to comprehend. And then perceptual motor functioning, including spatial ability and orientation, the practical application of which would be in how we navigate our physical environment, how we go around familiar places, and then how we go around unfamiliar places, and the ability for us to reorient ourselves in time and space. And then social cognition or behavior, our ability to kind of manage our social manners, our social inhibition, and to recognize social cues and behave accordingly. So what is dementia? Dementia is considered to be a decline in cognition from a previous level of performance, which means one has to know what the person was able to do in the past and then notice a change now, and to be able to confidently say that there has been a change. And that change should be such that it interferes with daily functioning. And the reason I'm bringing this up is because there is another term called mild cognitive impairment. And before we move to that, I also wanted to introduce this term neurocognitive disorder. So the more literature you read about this and the more organization websites you explore to gather more information, you will notice neurocognitive disorder is a new term that came out with recent publications of the American Psychiatric Association DSM manual. And there's a reason why they have now officially started using this term, though dementia remains the common practical term for most clinical purposes and for discussions between patients, doctors, families, caregivers. But if you look at the root word for dementia from Latin, it actually has a connotation of being out of one's mind, or the word mad or insane, and to be respectful, mindful of that's what this disorder is not. The term neurocognitive disorder has been introduced. Now, regarding mild cognitive impairment, there is decline in cognitive functioning, but it is not such that there's an interference in the routine activities of daily life, and the person is able to compensate and manage, and there are no major obstacle or difficulties noticed possibly by others. And also within these definitions is the clarity that these cognitive deficits should occur in the absence of other disorders. So in the absence of depression, in the absence of acute confusional states. So sometimes, especially older adults are at risk for going into acute confusional states in the presence of an acute medical illness or with hospitalizations. And all of that should be ruled out. Sometimes when a person is experiencing depression, they may not be able to concentrate or focus. They may not want to concentrate or focus, and therefore they may show lack of attention. And that truly may not be reflective of a cognitive disorder as much as a sign of depression. And so all of that needs to be looked into and ruled out before we say this is a true cognitive disorder, and then start considering dementia in our differential. I apologize for the small font in the next slide, but this is just to remind ourselves that Alzheimer's disease is the most common form of dementia. Dementia is an umbrella term that includes neurodegenerative diseases that affect cognition and result in cognitive decline. Alzheimer's disease is one of the most common causes that has been identified. Vascular dementia relating to loss of blood supply in the brain due to previous strokes is the next most common cause. And then dementia with Lewy bodies is the third most common cause. The differentiation between these three, besides the actual pathology in the brain, is also the manner of onset and the type of symptoms that may be noticed. So in Alzheimer's disease, it may be gradual onset, mainly memory impairment at first, and then other cognitive domains like language and orientation. Versus in vascular dementia, it is directly dependent upon the parts of the brain that get affected with the strokes. And in dementia with Lewy bodies, it mimics sometimes the motor or outward manifestations of Parkinson's disease, and some of the pathology in the brain may be similar. But what is commonly seen is that the cognitive impairment is noted quite quickly compared to Parkinson's disease, and hallucinations tend to be a common component of the presentation, and symptoms tend to fluctuate over time. Whereas in frontotemporal dementia, which affects the front part of the brain and the sides of the brain called the frontal lobes and the temporal lobes, which actually are responsible for our social behaviors and adherence to social cues, commonly what is first seen is lack of social disinhibition. So one may see people behaving in a more familiar manner with each other than expected, or sometimes exhibiting physical disinhibition, or using language that would typically not be appropriate for social situations because of lack of social inhibition. And so those type of symptoms may be more prominent and seen first in frontotemporal dementia. Whereas in dementia related to Parkinson's disease, the motor manifestations of the disease are noted first and are noticed for a long time, several years, maybe up to 8 to 10 years, prior to obviously noticing a cognitive decline. And that is how dementia with Lewy body is differentiated from Parkinson's disease dementia. Just a refresher on the demographics for dementia. Typically, onset is in later life, usually over the age of 65 years. About 14% of adults 71 years of age and older in the United States have dementia. The incidence tends to double every 5 years after the age of 65 years. And there's an approximate chance of, 1 in 2 people having dementia over the age of 82 years. Women seem to be more affected. About 2/3 of the cases involve women. So we did talk about the subtypes of dementia. So depending on the types of pathology in the brain, what type of dementia a person may have. But what about some of the common risk factors? Now, some of the risk factors are called non-modifiable, which means that they cannot be changed over time. For example, age cannot be changed over time, or a person's risk due to their sex status, male, female, cannot be changed over time, or family history cannot be changed over time. There is some information about genetics. I will not go into great detail right now, but the ApoE4 allele, and especially presence of 2 alleles, confers greater risk. And then personal history of stroke, I put that here as non-modifiable because obviously we can address risk factors for future stroke, but once someone has a stroke, then that becomes a non-modifiable risk factor in terms of having occurred already. There was some recent information published in the last few years by the Lancet Commission about what is called modifiable risk factors. And it stated that 35% of dementia cases, so that's approximately 1/3 of cases, could be attributed to 9 potentially modifiable risk factors. So let's see what those are. So education, less education is a risk factor. Hypertension, that is high blood pressure, especially in midlife. Then being overweight, and especially being in the obese category during midlife. hearing loss, depression in late life, diabetes, physical inactivity, tobacco smoking, and social isolation. And you will see that some of these are situational factors. So for example, social isolation, and we have had, a global pandemic in the last 1 year, and that has actually led us to believe that we may be seeing a greater propensity for cognitive decline because of this when we look at data in the near future. If you look at diabetes and physical inactivity and obesity and high blood pressure, it reminds you of all the vascular disease risk factors. These risk factors are very similar to what would be considered risk factors for other vascular diseases such as stroke, heart attack, or peripheral vascular disease of the legs or other blood vessels. And this reminds us, therefore, that all the general information that is shared about a healthy lifestyle in terms of diet, exercise, no tobacco use, all of that is very helpful in actually reducing risk of many diseases, including dementia. Now, regarding recognizing early signs of dementia, let's first talk about what happens with usual aging. Yes, one can see a mild decline in memory. One requires a little bit more effort and time to recall new information, but this overall mild decline does not impair functioning. New learning is a little bit slower, but still occurs. And actually, it's a good form of exercise for the brain for us to learn new information, new skills, because it makes our brain cells exercise and work a little bit more. So it's similar to how people do physical exercise, to build aerobic conditioning or to build muscle strength with resistance exercise. Similarly, training our brain by developing new skills over time, even in older age, is actually a good form of cognitive training for the brain. And quite often, we compensate with using lists, calendars, memory supports, reminders, alarms. But what happens when we get overloaded? So if you look at these two images, one is a set of bookshelves with the books neatly stacked, and think about it as the storage house of the brain and how it stores information. And it has the ability to store a lot, and then we have the ability to retrieve it when needed. But when the reserve goes down for whatever underlying reason of the dementia, then it cannot store as much. Some of those nerve cell connections are lost. Some of the storage ability is lost. Some of the ability to retrieve the information is lost. And then there's some confusion noted about what to retrieve, how to retrieve, when to retrieve, how to store, where to store. And so it becomes a little bit of a confusional state in the brain, similar to the bookshelf on the right. So let's look at the signs of what we call impaired cognition. That can occur in multiple domains. So there could be memory issues. Now, when we talk about challenges in planning or swallowing problems, I want to remind you that when there's a problem with physical tasks in dementia, it is usually not related to loss of muscle strength. So if the dementia is in a moderate to severe stage and someone is having difficulty swallowing, or someone is having difficulty walking, it is not usually because the muscles have become weak for swallowing, or the leg muscles or arm muscles have become weak, or the back muscles are weak to support for balance and to walk. It's more because there is loss of function without loss of strength. And there's a term for it called apraxia. We use that a lot. We call it speech apraxia, gait apraxia. So there's difficulty in swallowing without loss of strength of the swallowing muscles. There's difficulty in walking without loss of strength of the leg muscles. And that is part of the impairment in cognition and the damage to the nerve cells in the brain and the connections that leads to this kind of an outcome. There could be difficulty completing familiar tasks. confusion with time or place, difficulty with orientation, inability to reach places that were previously familiar, getting lost while driving, having difficulty finding words while speaking or writing, uh, misplacing items, but then being unable to retrace steps. So obviously we've all gone through this situation, especially if we drive automobiles and park in commercial garages, that we may forget where we parked the car once we come out of the mall or we come out of a professional building. And then we have to kind of think on which floor it was, what are the color of the car next to our car, or which floor did we enter the building, and we kind of try to retrace our steps. Now, that by itself does not equal impaired cognition where we start worrying, is this a sign of dementia? Because that happens on a usual basis to most of us, and we figure out a way to retrace our steps. And part of that is what I call cognition overload, the image that I showed you of the overfull bookshelf. So think about how much our brain can store, and then a point will come where we have to decide what is important to store and what is not. And that's when we start depending upon lists, depending upon calendars, reminders, and we figured out how to compensate for that. There can also be concerns about poor judgment, decision making, so people not making safe decisions or prudent decisions compared to what they used to do in the past. There could be some social withdrawal. There could be an obvious change in personality that others may see. Now, all of these signs can also be considered to be the 10 warning signs of Alzheimer's dementia. So I mentioned multiple symptoms in multiple cognitive domains, but these are the same items to consider when one is concerned about typical signs of Alzheimer's dementia. I also want to give you an organizational framework on how to think about overall the umbrella term dementia and then the subtype, the Alzheimer's disease dementia, that commonly how this can be considered to affect someone's daily activities over time, and how you could actually watch for if you have a loved one that you're concerned about, and how even your doctors or other healthcare providers who help monitor your loved one's behavior, how they could also help monitor the situation. So we divide our daily activities into 3 categories. One are the highly personal activities of bathing, grooming, toileting, transferring mobility, continence. And these are the easiest to perform for us physically because we have been performing these independently, ever since we were toddlers, and we were trained to perform this over time. And so now we probably perform these without much thought. And we become independent in these, as soon as we start going to kindergarten around age 5, 6 years. Now, what are instrumental activities of daily living? These are the activities that allow us to live independently in society, interact with each other. So the ability to communicate using a phone, the ability to go out and shop for ourselves, the ability to prepare a meal, manage, our living environment, like housekeeping, laundry, ability to manage transportation, and that does not equal ability to drive. So we do not say that if a person doesn't drive, that itself is a problem. A person may have never driven a car, and that's okay. But the ability to manage transportation, such as knowing how to get public transportation or private transportation and navigate distances and travel and arrange travel, and then the ability to manage one's own medications, the ability to manage one's own finances. Now, these abilities in the middle category require not just motor functions or physical ability, they also require some cognitive functioning or higher brain functioning. And then if you look at the third category, the advanced activities of daily living, you'll notice that those include activities that include recreation, spiritual pursuit, education, training, work. And these go beyond what is necessary to actually be able to live in terms of being for independent living and for personal independence. they add more to quality of life. They also demand much higher cognitive functioning. So if you look at these three categories, I actually have a question for the audience based on these three categories. So please look at them now and please try to answer my next question. And you can put it in the chat and the options are A, B, or C. And so you can just put in the letters. So my question is, what type of activity of daily living do you think would be most commonly affected first with the onset of dementia? So would those be the basic activity of daily living, or the instrumental activity of daily living, or the advanced activity of daily living? Which set of activities do you think would be affected first with the onset of dementia? So please, if you want to put it in the chat section. And the way my screen is set up, I may not be able to see the chat section. So Miss Alexander, you may have to tell me if you're seeing responses.
I am. We have quite a few C's.
Okay.
And a couple B's mixed in there. I think I saw one A.
Okay. So I am so impressed because I think this audience is doing as good or actually better than some of my professional audience when I teach at the College of Medicine. And so, yes, you understood what I was trying to ask and what I was trying to tell with this question, that because the advanced activity of daily living require more cognitive effort, they tend to be the ones that get affected first. As I said, the basic activity of daily living we have been doing for so long that by the time you're adults and beyond and as older adults, that we do them automatically. They require more physical effort and motor tasks compared to new cognitive components because this is overlearned behavior. So sometimes when one is concerned about the onset of dementia or a cognitive disorder, one way to kind of organize the symptoms or signs that you may observe is to see which type of activities are being affected first, and then see if you start seeing the next category being affected. And so quite often the advanced activities may be affected first, followed by the instrumental activities, and then the basic activities get affected last. But there can be overlap, so it is not that only all the ADLs have to be affected and then only the IADLs get affected. There can obviously be a common position and time and overlap where some ADLs and IADLs get affected first and followed by the basic ADLs. Differentiating between terminology, I also wanted to talk about what we call alarm signs that may reflect a severe stage of dementia, irrespective of the cause, but it obviously also includes Alzheimer's disease dementia. And these are called alarm signs because they flag the possible need for 24-hour assistance or support or supervision. And so if one is unable to perform personal self-care, so once the basic activity of daily living start getting affected, that person may need more support. If there's impaired judgment or a concern about potential harm to self or others because of impaired judgment, the person may need more supervision and support. And if the concerns about actual personal safety due to physical environment reasons or the lack of ability to seek help in unsafe situations, again, that may be a concern. So quite often in clinical situations when we are interviewing our patients and their caregivers, one of the safety questions and judgment questions sometimes we usually inquire about is that we may give a hypothetical situation to the patient and ask them, God forbid if there's, a disaster or a fire or some other acute environmental emergency in your living environment, what would be your next step or how would you seek help? And then we gauge from the patient's reaction whether they are at that time capable of making some safety decisions if left alone in their physical environment, and also allows caregivers and families to kind of think through based on their loved one's response where they are in terms of the type of supervision and caregiving they're providing to their loved one. I just wanted to come back to some terminology again, and this is not to confuse all of you, but just to let you know that when you read professional literature, sometimes based on the source of the term, you may see some different terms. So the National Institute of Aging and the Alzheimer's Association have also some additional terms over time, especially relating to Alzheimer's disease. So preclinical disease is typically not considered in the clinical world. It's typically considered in the research world, where they are now considering whether they are able to identify certain biomarkers even before you see the outward manifestations of the dementia process in Alzheimer's disease, and how that could be tracked over time to see if one could predict changes over time. Mild cognitive impairment, we already talked about, where there are mild changes in cognition. They can be measured with some formal mental status tests, but the changes are not so severe that they actually affect a person's day-to-day activities. And then probable Alzheimer's disease. So you will see two words, probable or possible, in the literature. And that's because there is no way to do 100% diagnosis of a dementia subtype without actually looking at brain pathology. And obviously we do not on a routine basis do brain biopsies, of persons with whom we're suspecting they have cognitive decline or dementia. So quite often, some of this information comes from autopsies done on brains after death. And therefore the word probable and possible is used because this is the closest you can get, because the 100% diagnosis is based upon actual pathology seen in the brain. And so it tends to be a diagnosis based on clinical grounds, based on exclusion of some of the other things I talked about, like exclusion of acute confusional state, exclusion of depression, exclusion of other treatable, identifiable conditions, and also the progression over time would be included in that definition. And so coming to objectives in terms of recognizing the spectrum of severity of dementia. So there are various ways to classify. One of the simplest ways to classify stages in Alzheimer's dementia and even other types of dementia could be, the simplest is the three categories: mild, moderate, or severe. The mild is one where symptoms are not that obvious. The person is typically able to function independently. When they interact with others or the environment, it may not be that obvious. Moderate tends to be the longest stage. The person needs more and more assistance with daily functioning over time. And as mentioned, it may be the AADLs and the IADLs that get affected first. And therefore, quite often, we see that sometimes with persons with cognitive impairment, there may be family members, caregivers, friends taking over some of those tasks, such as balancing the checkbook, managing finances, or helping with medication so that there's proper medication use without medication errors. And then the severe stages where the person may become very dependent in their personal activity of daily living, the basic activity of daily living, and then ultimately may require 24-hour assistance. I'm going to mention a scale that is typically used practically in defining stages of dementia, and especially with Alzheimer's disease. It was developed by Dr. Reisberg. And again, I apologize for the next slide, which may have small font, but I won't go over all the 7 stages. I will just mention a few to tell you these numerical stages are very helpful at times, especially when one has to consider prognosis over time and what one may expect over time in terms of loss of functional ability. So stage 1, there's typically no obvious visible difficulty. And then stage 2 starts with subjective difficulties, sometimes at work or school or in formal situations, and then progresses in stage 3 to, again, work, recreational, educational environments. So typically AADLs and some IADLs may get affected. And then once it starts progressing further, then in stages 5 and beyond, it starts affecting basic activities, including grooming, bathing, toileting. And then stage 7 is the most severe stage. And quite often, patients may not be able to, persons with dementia may not be able to walk without assistance. The speech may get limited. Their sitting balance may get affected. So when they are helped to sit in a sitting position, they may need support to stay seated with good balance. And ultimately, stage 7F, the last stage, refers to the inability to hold up their head and neck properly. And this is good to know for functional reasons when caregivers are trying to help their loved ones, to know this, because if someone is not able to hold their head up properly on their own, then when you're trying to help them eat and if you have to feed them, then you would need to know proper procedures for how to support their head and neck so that they're able to swallow in a proper head neck position. I'm just quickly mentioning some non-pharmacologic approaches. I'm not going to be talking about treatment of dementia or mentioning medications in the interest of time and also based on our objectives here. But I wanted to remind everyone that similar to how we promote physical exercise for cardiovascular health and general well-being, there is some information about cognitive training. It is not that well proven that we should start officially prescribing, mandating, and making it part of a recommendation all the time and every time, because we don't know the exact type of approaches that may help. Because of the diversity of the studies done, we don't know exactly like one approach that may help. But as I said previously, that exercising the brain is a useful way to keep the brain active, and especially development of new skills allows the brain to make more connections within itself with each other and some of the connections that it had lost over time. So some type of cognitive training may be useful. Physical and mental activity, so keeping busy. Appropriate education of the loved ones, the caregivers, and being part of a support group so that you know you're not alone, you know you can lean on others, you know you can share information, you can exchange information, you can ask for emotional support, you can ask for respite services sometimes. And then also paying attention to safety. As I mentioned previously, once the condition is in severe stages or moderate to severe stages, safety concerns come to the forefront, and that should be reviewed and strategies put in place on how to keep the person safe, the environment around them safe, and others safe. And then there may need to be some environmental modifications. Initially, it starts with supportive strategies, reminders, cues, some supervision, and then also sometimes structure helps persons kind of stay in their routine. So maintaining a daily routine is sometimes helpful. Now, the last objective talks about palliative and hospice care services for persons with advanced dementia. So this part of my talk is focused on the severe stages of dementia and severe stages of Alzheimer's disease type of dementia. And again, I wanted to introduce some terms. We may have heard of terms such as palliative care. And I wanted to remind everyone that palliative care is not restricted to one stage of illness or to one stage of life. If you look at the root word palliare, it means to cloak or to provide covering or to provide relief. And so palliative care focuses on symptom management, that is relief of suffering. And it can be part of ongoing treatment that is considered curable for a particular condition, but it can also be used all the way towards the end stage of that condition, including end of life situations. And so when someone comes to a doctor with a sore throat, typically, after taking the history and when doing a physical exam and after looking at the throat, we may consider some diagnostic testing to figure out whether it's a bacterial infection or not, or whether we think by history it's a viral infection. And whether we decide to prescribe antibiotics or not, we will pay attention to the symptoms the person is suffering from and try to then give them advice on how to manage the symptoms. So whether that's pain in the throat, whether that's fever, whether that's cough. So ultimately, we will try to help palliate those symptoms. That is part of palliative care. And so it is done in parallel with what is called curative type of care. Palliative care should be promoted for a variety of reasons: to anticipate what could come next, especially with chronic conditions, to try and prevent some of the functional losses that may occur with those chronic conditions, and to actually treat the suffering and the symptoms the person may be going through because of the symptoms. And it is in line with trying to honor a person's personal goals of care. If you review personal goals of care for most people, symptom relief will usually be one of the goals, and then optimizing function will typically be one of a person's personal goals, and then wanting to stay independent. So the next pictorial depicts the usual trajectory of care, especially for a chronic illness. So if you start from the left and you see the line that goes through the middle from the bottom left all the way to the top right, you see the upper triangle marked curative care, the lower triangle marked palliative care. So at the onset of the illness, both types of treatments are being administered and offered to the patient. Curative care to try and treat the underlying cause of the condition if possible, and palliative care to try and manage the person's symptoms over time. Now, based on the progression of the illness over time, there may come a point in time when that chronic illness has reached its most severe stage or end stage, where curative care is no longer providing any added benefit. And the focus then changes to palliative care, trying to optimize symptom relief, trying to optimize function, trying to address the person's personal goals. And at the time of death, beyond that is then the bereavement, grief experienced by the loved ones, family members. And so this will be the typical trajectory of a chronic illness. Now, if you look at the next diagram, you'll see it is very similar, except now it has the added intervention of hospice. So what is hospice and what can hospice do and where does it come in the trajectory of care? So once a condition may be nearing very severe stages, nearing end stages, where the treating clinicians determine that there's a very poor short-term prognosis for that condition, for that person, then hospice interventions may actually prove to be beneficial. So let's talk a little bit about what hospice can do. But before I move on from that diagram, I just want to show that hospice doesn't just help the person, but beyond the person's death, it also helps the family with bereavement, grief, and so it does not stop with just the person. It's addressing concerns related to that person, but also their loved ones and caregivers. So I did mention a little bit about palliative care, focusing on, physical and emotional suffering. Hospice is a little bit more, and especially in the United States, a time-bound benefit in terms of the clinicians predicting that if the natural history of the illness progresses over time, then in their best clinical judgment, the prognosis is 6 months or less. And also the person should want to or elect to focus on palliative measures and comfort measures and not be interested any long in curative treatment, and that quite often matches the time when clinicians will typically educate patients and families about the lack of benefit of ongoing curative modes of treatment. It comes from the root word in Latin, hospes, meaning host or guest, and that's why you'll see that it is all-encompassing. It's the attitude, behavior of a hospice team, a hospice agency is always very welcoming. And usually the response does not include no, And this is something I learned over time because I have been a hospice medical director for some time, but I have worked with hospice for a long, long time. But this is something I recently learned over time, how the manner of behavior, the manner of interaction of the entire interprofessional team and hospice, the attitude is such that the typical answer will usually never be no when a patient or a loved one has a concern that they express or they need some assistance. The answer will typically lie about how, if we can't help, how can we direct help towards this person or their loved one. So that's one of the approaches I absolutely appreciate about hospice. In the United States, it has lots of different meanings, from a Medicare benefit to an agency or an organization that provides such care, to an actual site of care like an inpatient unit, where if a person is having uncontrolled symptoms that cannot be managed at their current location, such as home or assisted living or somewhere else, they can be brought in for short-term care to help their symptoms. And it's also an approach to the care of dying patients. Not all patients or persons in end stage of any condition enroll in hospice services. It can also be used as an approach to care. And so sometimes, for whatever reasons, if a person does not enroll in hospice services officially, their caregivers and their clinician and treating team can still use a hospice approach to care while they're trying to help the person. The team is typically an interprofessional team, and I highlighted the fact that the patient and the family and caregiver are actually the captains of that team, not the other professionals. And all the other professionals play different roles, but they don't stay camped in their particular roles. They usually end up getting cross-trained just by the nature of their work. And so sometimes when a music therapist is doing a formal session with a patient and they noticed some symptoms or they notice something else, they may typically go back and inform the nurse, who may then need to intervene with something else, and the nurse may notice something else regarding psychosocial support or services, and the nurse may then contact the social worker. And so everyone works together as a team to help the patient and the caregiver. And there's no restriction on where a person has to be to receive such services, so they can be provided in any location in terms of following the patient and visiting the person. And the types of services that are typically included besides professional services is coverage of many of the medications and the supplies and the equipment, as well as respite care at the inpatient unit, where the loved ones can have the person with the advanced illness, and in this case, it would be advanced stage of dementia, already enrolled in hospice, so that the caregiver could get some respite for a few days for themselves. And last but not the least, what is hospice and what it's not. So it's not a hands-off approach. It's not driven by the clinicians or the professionals. It does not stop when a person dies. It is not disjointed or fragmented care. And I also wanted to emphasize that it does not hasten death. There seems to be a incorrect assumption sometimes by people that enrolling someone in hospice or hospice interventions actually will hasten death. There have been studies that actually have shown that in many situations, hospice may actually promote prolongation of life, though that may not be the original intended goal in any way, either way. But think about what happens to someone who is acutely ill and is in the hospital for the nth time for an acute exacerbation of their advanced illness. And especially in persons with dementia, one of the risks they have is being susceptible to infections, being susceptible to falls. So quite often, pneumonia, urinary tract infections, falls, hip fractures tend to be the modality that bring a person with severe dementia closer to end of life and death. And if someone in that situation gets hospitalized, we do so much in the acute hospital environment because as clinicians, we are trained to do that. That is the environment where everything is measured, everything is reacted upon, every little number of a blood test, every little number of the cardiac monitor gets attention. And sometimes we lose sight of the person and we start treating data and numbers rather than the whole person. And in all of that well-intentioned effort on our part as clinicians, we forget sometimes that the body may not be able to handle it at that stage of that illness. So sometimes when such persons are discharged from hospital to hospice services, and all of this poking, prodding, measuring, reacting stops, it sometimes allows the body to heal on its own over time. So it's not surprising sometimes to actually see persons get better for some time because now the body is not being insulted by professionals like me who are trying to go after data and manage that information rather than looking at the person as a whole. And what is hospice? It's compassionate care, patient-centered care. It treats the patient and family as one unit. It's coordinated, it's holistic, it focuses on symptoms, and it's evidence-based. It's not just the art of medicine. We actually now have enough literature out there to start recognizing sometimes that, for example, when we are treating symptoms, that sometimes some of the medications we use may have side effects. So we don't always think of everything that a person is exhibiting as a new symptom that needs to be treated with new medication. Sometimes we need to take a step back and see, okay, maybe we are giving too much medication. Maybe we need to adjust medication. So there's a lot of science behind hospice modalities of care. And we are close to time, so I am going to stop. Just to say that dementia is common, but it's in older adults, but it is not an inherent part of aging. Alzheimer's disease is the most common type of dementia, and that the primary goals of care, especially in severe stages, usually focus on enhancing the quality of life of that person and maximizing function. And there are available community resources that should be used by the persons affected with dementia, their family, and caregivers. And thank you for listening. And if you have any questions, please feel free to ask.
All right, so thank you, Dr. Suchak, for that very in-depth presentation. I have learned so much about dementia through your presentation. And we have a comment here from David Wheeler, who says, it is clear to me why Dr. Suchak is the recipient of a teaching award, because you are just an amazing teacher. Lots of thanks going out here in the comments. We do have the Q&A section open. We have about 5 minutes remaining. So if you do have any questions for Dr. Suchak, go ahead and drop those in the Q&A box. I also see that our next presenters are here. So we will be, as soon as we close out Q&A, we'll be introducing them after I give a highlight to another one of our session sponsors. Again, Dr. Suchak, so many people are in the comments saying, wonderful presentation. Thank you so much. Very informative. Thank you, thank you, thank you. So everyone seems to have loved all the information that you have shared with us on today. And I'll just pause for just a moment to give space for a question. If you have one, again, go ahead and drop that in the Q&A portion. I also want to say that for those of you who may have joined in the middle of her session or since the very beginning of the conference, I want to remind you that for those of you who are requesting CEUs, we will share the information at the end on how you can request to get those CEUs and pay for that. Also, we want you all to be interactive, so feel free to continue to use the chat, continue to use the Q&A box to ask questions. Let's see, we've got a couple more comments that have come in. Connie Sunquist says, thank you, lots of information to help me. Philip Nowicki, forgive me if I mispronounced that, says, terrific presentation, most informative 45 minutes I have ever heard. That's a serious compliment right now, right there. And then also, we do have a few questions coming into the chat. So first question is from Jennifer Van Dyke, and she asked if we could get a copy of your slides. If you don't mind, Dr. Suchak, emailing those to me, I will make sure that they get included in the packet that will go out to the attendees next week with all of the resources.
Absolutely. And if there's anything in the slides of copyright issues that I cannot distribute, I will include all the proper references so you'll know where you can actually see, because all of this information that I have used is publicly available. So if not the actual slides, I will absolutely include the appropriate references.
Excellent. We have a question from John Trombetta, who is saying, as generations begin to rely on electronic methods of memory support, like calendars, emails, etc., will they be as effective in assisting with aging? Has there been any research come through on this?
I am so glad that you are asking this information, especially not so much for dementia right now, but there are mobile technology being used for research, not just in the United States, but internationally, because when I present internationally and I hear about international endeavors, I find out these things that they are being used for patients with multiple chronic conditions, older adults who tend to have multiple chronic conditions, to actually figure out ways to make them more independent and autonomous and how they manage their conditions and communicate. And so similarly, I can almost imagine even what we do routinely in our day-to-day life in terms of reminders and routines and alerts and alarms, that I can consider that in the future, there may actually be some sort of formal ways to intervene where cognitive training and reminders and participation, including group therapy, the way we do for other chronic illnesses, could probably be considered effective and practical. So thank you for reminding me about this, Mr. Trombetta.
That was a really great question. Well, let's say thank you once again to Dr. Suchak. We've got all kinds of questions coming in. Let's see. Holly Jane Aldridge asked, how do you know when they have changed to the different stages?
Okay, and so if you're talking about like mild to moderate to severe, some of it is dependent upon, as I had mentioned, the 3 different categories of activities of daily living that may help quantify it. So in mild stages, usually the advanced activities, the instrumental activities may get affected, but it may not be noticed by others. It may not have a big impact on daily functioning as much, and a person may be able to compensate. The moderate stage tends to be the longest, where it will be noticed by that person, will be noticed by other. There will be obvious impact on IADLs, sometimes also in terms of progression over time with the basic ADLs. And once many of the basic ADLs get affected and there's actually loss of independence in the ADLs and many of the IADLs, you know that the person has reached the severe stage. And severe stage typically requires almost a lot of assistance from others, sometimes 24/7 assistance. So in a general sense, that's how you could figure out when one has moved from the mild to the moderate to the severe stage.
Okay.
And there's I think a comment about physical exercise, and absolutely in one of the slides on non-pharmacologic interventions, I think I had mentioned that. So similar to training the brain with cognitive training, doing physical exercise helps, because anything that helps a vascular condition will help the brain, because the brain depends upon blood supply a lot. And so the way we do all the lifestyle factors, we try to improve diet, exercise, no tobacco use, things like that, low salt. All of that helps our vasculature. It helps reduce the risk of the clogging, the plaques, and the blood vessels everywhere are affected, which means the heart function could be preserved better, brain function could be preserved better, kidney function could be preserved better. So therefore, physical exercise is one of those interventions that does help in many illnesses, including trying to preserve cognition or delaying cognitive decline. So thank you for that reminder again.
All right, and we'll take this one last question and then we've got to wrap things up. A question from Patrick Hogan asking, how can we best bring more attention to the value of geriatricians?
I don't know how to answer that, but I will say this much. that as geriatrician and as a trained, fellowship trained geriatrician, we do realize, and as part of the American Geriatric Society, that there will never be enough trained geriatricians in the United States to treat every older adult. And so what our effort has been over the past couple of decades nationally, including our medical school here in Tallahassee, is to train all of our learners in geriatric principles so that even if they become different specialists over time, whether it's a cardiologist and a heart doctor or an ophthalmologist and an eye specialist, that if they have an older adult as a patient, they are able to apply the geriatric principles of care. So there have been national efforts through the American Geriatric Society and others to introduce training principles in surgery, in different specialties of internal medicine. And now we are moving on to other professions, from nursing and other professions. So I appreciate the thought, but anything the public can do to help promote that effort, I would appreciate it. And not to say anything about other healthcare professionals, but one of the common comments I hear is that, why do you need a geriatrician? I have been practicing geriatrics for so long because more than half of my patient population is over the age of 70. So if I have older adults in my practice, I am a geriatrician. So from my own colleagues, sometimes it's disheartening to hear that they may not value the perspective of a trained geriatrician. Thank you for your comments.
Thank you again, Dr. Suchak. This was very, very rich. We appreciate you sharing your wisdom and your knowledge with us on today.